Good afternoon, everyone. Thank you for joining us for today's Lunch and Learn session on how to choose a health benefits plan. The purpose of this Lunch and Learn is to provide you with the tools to shop and select a health benefits plan that best suits your needs during this open enrollment period. A couple of housekeeping items before we begin. We are recording this session for future on-demand viewing for your coworkers that were unable to make it. We ask that you remain muted. If you have any questions throughout the presentation, please put them in the chat box, and Sierra Bradley, our lead research associate, is going to monitor those questions that will be addressed at the end of the session. I am pleased to introduce Kevin Lyons, who is the Legal Protection Plan Administrator and Health Benefits Coordinator for the New Jersey PBA. In addition to that role, Kevin is a member of the Plan Design Committee. So without further ado, I'm going to turn it over to Kevin to get right into the presentation. Thank you, Kevin.
Thanks, Lori. Thanks for the opportunity to talk to some of your members here and go through what we try and convey this message to our members. One of the things that when we talk about you choosing the right health benefits plan for you and your family, it's always a very personal decision, right? Everybody has specific needs. You have specific offerings by municipality. So it's really, there's a litany of different combinations of things that come into play when we talk about choosing the plan that's best for you. So please don't be afraid to ask questions. I do have to qualify that I'm not here speaking on behalf of the Plan Design Committee. They have these stupid ethics rules and they'd love to hang me out to dry, but that's not going to happen for that little thing. So just a couple things I want to go over with you. The increases for 2025 are astronomical again. The state's good at some things. One of the things that the state is not good at is running a health benefits plan. You know, that I've been intricately involved in this for about 15 years now. They have an old mindset in a lot of ways. I think they're good. They're well intentioned, but we don't have a medical director. We don't have pharmacists on staff. We don't have all these other big state plans have these things to monitor trends and monitor. We have great people working there. We have analysts and all, and they do a good job, but they're just overwhelmed. They're so understaffed for a plan of our size with 800,000 lives. Ultimately, is what they're responsible for. So the increases again are 16%. What we've drilled down on is that the utilization was only up 0.6% for local government. So 3% of that increase is because the state wants to rebuild the claim stabilization reserve fund. 2% is for adverse selection because the healthier people are leaving. So you see on the state side, they're about 10% increase. They put these buffers on the local side because they don't want the state to have to kick in any money. And what the state did was, once again, subsidize state workers in their rates, like they did with the year the 24% increase. So the state workers are not feeling it as much as local employees are. And just by way of background too, I'm a retired cop. So I worked for Long Beach Township for 25 years. I'm in the state health benefits plan. They provide my benefits. Luckily enough, I was out before Chapter 78 got a piece of me, so I don't contribute. So these changes that I vote on and I bring to you, you know, I try and walk the walk too. So they all affect me as much as they do you. One of the big changes, if you saw, we had a special open enrollment a few months ago. Aetna is an option. When you get down into the weeds, Aetna actually has a lower cost basis, but the state won't bifurcate the two rates. So essentially, Horizon's getting the benefit of Aetna's lower spend, which I'm trying to drive my members to Aetna. Like for me, I've been under the Blue Cross system since I was born until July, and I switched over to Aetna because I know it's the better thing. So, let's see, I'm trying to do this for you. All right, so I just want to go over some definitions so you can understand in-network and out-of-network. The providers agree to be paid. They sign a contract. What we're finding out is that we were always told that in-network was a lot cheaper. It's not the case. Because of some misaligned incentives, the hospitals and the insurers have no reason to drive down what they pay. We've found that some hospitals in-network are getting 7 times Medicare for in-network services. So we're seeing that the hospitals are the biggest cost driver in our plan. Out-of-network costs are indexed in 2 different ways with the state of New Jersey. Direct 10 and 15, and I think 25, 15, 25, and 2030 are all indexed at 90th percentile of fair health. The other plans are indexed. The Unity plan, or the 2019 plans, they're indexed at 175% of Medicare, which is a little bit lower. Probably about 20, 30% lower, depending on the service. So that's what you end up paying. You want to look at the network quality, right? You want to make sure the network fits your family's needs. And one thing to remember when we talk about Blue Cross and Aetna, Blue Cross is not truly a national network. Blue Cross is a network of several different insurers that get together under one umbrella, the Blue Cross Blue Shield network. It's not one. It's definitely not one network. So when you cross a river, you're actually paying more for services, but because they add fees and things like that, or when you retire. Aetna is a true national network. So if you look at the tiered network plans, which are Omnia and Freedom or Liberty Plus, if you look at those plans when you're shopping, and you decide to go to a tiered network, Aetna is really, and once you leave New Jersey in the Blue Cross Omnia plan, you're tier 2 for everything. In the Aetna plans, you're not. So it's just something to consider if you decide to do that, because when we talk about it, you're going to see that they're about 30% less, the tiered network plans, which may not work for everybody, but it may be a bridge while we figure out the problems that we're trying to and control costs on the state level. It might be something that you can go with. And deductibles are it's the first monies you pay. If some of the plans have $100 deductibles now, the PPOs, I think that the 2019 plan has that built in for the first $100 you pay out of pocket, except for maintenance. And I'm sorry, not for maintenance, for preventative care. You don't pay for that under anything, even the high deductible plans. All right. So not a big issue with out-of-network services and all these plans. There are deductibles. Copays, we all know what copays are. It's your share of the service in network. Co-insurance is the portion you pay out of network, right? You're going to pay 20% up until the maximum out-of-pocket. The out-of-pocket maximum is indexed every year except in direct 10 and 15. Limits and pre-approvals, there are, like with chiropractic care, I think it's 30 visits a year. When there's certain balances with durable medical equipment, and there's always a pre-approval process with a lot of those things too. So one of the cost saving things we're looking at, Oregon did it, Montana had done it for a while, what's called reference-based pricing, right? What we do is just we pay a cost for, we set what we're going to pay. We don't let the insurers negotiate what we're going to pay. We think we can save about 30% of our spend by doing that. It's probably somewhere we're going to end up down the road. So, all right, here's just an illustration of what we've gone over in the past few years. If you look at Direct 10, which it's still, even with the high cost of it, most municipal employees are still in this plan. The majority are still in this plan. They're just, one thing in healthcare and in migrating from plan to plan that you find is that there's so many people that there's an inertia, right? So when you have inertia, it's getting them to move. And lately it's been like they're the frog in the pot of water, right? the heat's turning up, heat's turning up, heat's turning up. But if you look, family plan for Direct 10 from 2022 to next year is up 50%, essentially. So it's going to be $50,000 for my members that on top pay. They're looking at paying over $17,000 for that plan. So, you know, they're going to be forced to move away from that plan for financial reasons. It's still going to be offered. Nobody's brought to the table to remove it. That's a constant rumor that I hear. That's never been on the table to do away with Direct 10 or 15. And if you look at the comparatively, Omnia is about $16,000 less a year overall, and the members there would be paying. I have it. You know, 35% of that is about $8,000 a year. Or wait, no, I'm looking at 2022. But you just see the drastic change between the two of them. So, like I talked about, hospitals. If we paid hospitals 150% of CMS, which is certainly where they can make a profit, because they're benefiting in two ways. They're getting higher payments for procedures, and they're also getting the tax rate breaks under the pilot programs. So we could save over $1.2 billion a year just by doing that. Drug costs, you know, everybody talks about GLP-1s, the weight loss drugs, but it's really not the GLP-1s driving the cost. Well, we were faced with plan design changes this year. If we eliminated them for weight loss, it was only going to save 1.6% on the rate. To me, that juice wasn't worth the squeeze. The real spend is specialty drugs, like the cancer medications, a lot of the things you see advertised on TV. In the healthcare circles, there's a joke that anything they advertise pretty much doesn't work. You know, that's why they do it. And one of the things we're looking at comparative effectiveness research and looking at the actual clinical trials to determine what our formulary is going to be. So if you look at let's say, Ubrelvy is a migraine medicine. Well, the old migraine medicine that's on the market costs about $5 a pill. Ubrelvy is $90 a pill and has lower clinical efficacy than the old drugs do. Just because it's new doesn't mean it's better. You know, so those are some of the things we're looking at and what's probably going to be coming down the pike. So once again, lowering things we're looking at is lowering the index, increased copays for specialty and urgent care. The state did that for their employees. They went up to $45 for an urgent care because urgent cares are mostly owned by hospitals and get paid on hospital scales. So if you go to your primary doctor, it's usually about $65 for a visit. If you go to a urgent care, it's about $300 for the visit. And especially if they're out of network, then it's probably more. Drug costs, like I said, use of health reimbursement accounts with lower cost plans. That's a lot of you have seen the difference card. That's the commercial name for it. They came up with a program to save the towns over Direct 10. It would save the town and the employee about $3,000 each to go to 2035 and then use the difference card to make up the difference in the two plans and bring it back to the level of Direct 10. The state does not like that plan. They have dragged their feet as much as they could with getting get the towns that want to implement it. But there is a cost savings. I suggested my old employer go to it. And everybody that's come to me, I've said, give it a shot. It's not a long-term fix, but once again, we have to get through this crisis right now. All right, just so you know, the design committee is 6 from management, 6 from labor. So we're the ones that make the changes. You need 7 votes to change a plan design. The problem is that there's 2 bodies. There's 2 bodies with that. You have the commission who does all the contracting and us who do the plan design changes. We just implemented a huge plan design change with centers of excellence. The state then has the contracting responsibility, and the administration controls the commission. So what becomes problematic there is that they may not be in line with what we're trying to do. So we need you, as you know, the leaders in your town also, to look and shop around and be fiduciaries to their plan. If you're in the, you know, we need more fiduciary oversight. Brokers are very active right now. I just went and talked to a town up in Passaic County. The broker is trying to bring them into the low, the HD low plan, which will save them huge premiums and share some of the savings for the town in an HSA, which is a long-term vehicle to cover the expenses in a high deductible plan. So if your town offers these things, don't just say, no, I'm not doing that. Look at it. It may work for you. If like I always say, my young single males are most of our new hires in police work. They're going to go to maybe get a physical once a year if they don't have any medical. I'm like, why are you in direct 10? You don't need that level of coverage. So we try and when I talk about, it's very personal. And as you get older, you get married, you're going to have a child. Yeah, okay, I could see moving up to a plan with higher actuarial value, but in those beginning years of your life, I'm not so sure you need it. But the problem is they go in the locker room and they say, oh, that's the best one, take it. Well, why are you going to pay that much money? You know what? Why pay $17,000 a year once you have a family if you don't need it? So GIFs are, I'm just going to touch on this. We're mostly talking about the state plan, but some of you may be in a GIF. GIFs, I don't like the governance of GIFs because they're cloaked in secrecy, and generally a lot of times town leaders are getting paid for being on the board. So I think there's some conflicts there, but overall it's a vehicle that you have to look at right now with the cost of the state health benefits plan, because like I said, the state is not being a true fiduciary with the state plan. So our plans are all above 90th percentile of actuarial value. That means for every dollar of healthcare you spend, the plan's going to spend 90 cents, you're going to spend 10 overall. You know, it's not, they're talking about across the whole plan. They're all platinum plans, I think it would be called in the exchanges. But look at both the network quality and the benefits, not the AV all the time, because if you look at Omnia's got a much smaller network, but at the same time, the actuarial value on that plan is still in the mid to 90s, I believe. So you want to make sure that your network's adequate. The state's not supposed to contract with anybody unless the network's adequate. You want to look at that. You want to look at in-network and out-of-network because you'll have less exposure. It doesn't necessarily save the plan money, as I said before, but at the end of the day, you really want to make sure that you have adequate doctors in there. EOB forms, always check your EOB forms. What I found is that my personal experience, I think Aetna does a much better job with their EOB forms because you can actually see what they spent for each service. And one of the things we saw, Horizon came to the last meeting of the design committee and presented their pricing transparency tool. And I asked the question, is that the actual amount that we're paying at that facility for that service? And the answer, they aggregated it. So they averaged it out across everything. So you really don't know. So you should really find out. One of the big things I'm on right now is hospital transparency. And they cloak everything in secrecy, even though the Consolidated Appropriations Act of 2021 said that they had to have it posted in machine readable form. Look, go on a Hackensack Meridian site. There's 500,000 lines of data. So how to find out what your procedure is going to cost you is absolutely, it's daunting. I can't figure it out, so I don't expect anybody else to. Once again, in-network costs, you know, you just want to see, you're going to have the co-pays in-network, co-insurance for surgical centers and durable medical equipment. Some have deductibles, very few, but then you reach out-of-pocket maximums. In Direct 10, there's a $400 out-of-pocket maximum. It's almost impossible to reach. That means you have to go to the doctor 40 times in a year if you're paying a $10 copay. It generally only gets touched in some of these other services. Way out too, when you're talking to your doctor about drugs, prescription, say, listen, is there generic for this? Is there, because you're going to pay a lower copay. Now the disparity in Direct 10 is not much. Also utilize the mail order service if you can, because then you get 3 months for one copay. So you want to tell your members to do that. So out of network costs, the problem with out of network costs is that there's a lot of providers out there, because we have a higher index that we use, 90th percentile of fair health, that they're happy with just taking what the insurer pays, which is illegal. It's against the law. They have to collect the copays and the coinsurance and the deductibles. A lot of providers are very happy, but taking that, but it kind of undermines the plan design of each plan when they do. A lot of times at 175 of CMS, they're going to want their deductible. So make sure you have that conversation. You're a consumer when you go to the doctor, right? The doctor isn't your boss. You say, all right, well, what does this cost? Ask them what it costs. And so you can make sure not only do you protect yourself on the copay and coinsurance side, you're also protecting yourself with the bigger picture of the plan. Make sure you're getting the value for what you're charging. And look at your EOBs. You'll be astonished with some of the services we pay. This is just an illustration of what you can be exposed to. So
I didn't see it. I was out.
Can I ask if everyone please mute themselves?
So if you look at this, if in a $2,000 service, so the insurer negotiated $480, you cover the $20, and the rest is waived by the doctor because of his network agreement. At a network, there's no network agreement, so you can be subject to balance billing. So you have to make sure you negotiate with the doctor and make sure that it's adequate. And then I'm just going to skip this. We're not getting into it. The prescription plans, we use what's called the National Preferred Formulary for Optum Rx in the state of New Jersey. And what we're finding is that there's a lot of lawsuits out there about the PBMs. There's actually the DOJ, I think, just sued 3 of them, the 3 biggest ones. There's essentially only 3 big PBMs that can handle something like the state of New Jersey. It's Optum, CVS, and Express Scripts. Express Scripts is owned by Cigna, Optum's owned by United Healthcare, and CVS it actually owns Aetna. So you can see how the consolidation is driving up prices there. We do have mandatory generics now in the state. So if there's a generic available, you have to take it unless there's a medical reason that you can't. Some step therapy uses the lower cost drugs first. The new drugs coming on the market, like I said, the GLP-1s, it's a tremendous spend. It's 1.6% of our overall rate, like for just for weight loss. But the biggest spend is like Humira, right? That drug can be anywhere up to $7,000 a month for people, and they go on it, and clinically, it only works for 50% of the people who take it when you look at the data. So, but people go in and say, I want that drug that they advertise on TV, and we end up paying the bill for it. And that's what's driving costs. So there's some other vehicles. I talked about the difference card before, which is an HRA. You can put that with high deductible and other plans. The FSA is that what you should all have that within your town to cover your copays and deductibles. What's good about that is that money comes off your tax bill at the beginning. So $1 you're saving tax money on, and a lot of people are worried, well, the employer gets it if you don't use it. Well, just start small. My family, we go through $3,000 a year. Start small and just step it up. You're saving tax dollars. HSA is when the employer contributes money and it stays in the account for you. It's your money. And it will grow over time. The neat thing about an HSA, if you're offered a plan with that, at age 65, that's your money. you don't have to use it for medical stuff anymore. So we just, there's some tax implications there at 65, but there's no penalties. And an HRA is just a reimbursement account. It's the employer's money, and that's the model the difference card uses, if you've heard of them come around. So what I'd like to do now, I think I'll stop for questions if anybody's got any questions. And then I just want to walk you through the state website. I guess I should stop screen share right now.
Kevin, we do have a couple of questions in the
Okay.
chat box if Sierra wants to read them aloud for folks.
Sure.
Okay, the first question was for Magda. It was asking if, when you had this screen up, is this what we be paying out of our paychecks when you were doing the percentages in the beginning slides?
Everybody's contributions on the local side, if you're in a PPO, are going to go up 16%. Because the premiums went up 16%. Since there's so many variants in that the scale for Chapter 78, it would just be proportion. It'd be 16% proportion.
Okay. And then another question was, what was the note on the JIF hybrid between private plan and question mark?
The JIF between hybrid. Oh, it's hybrid. It's a public plan, right? Because it's a public entity, but it's controlled by a different entity, a non-government entity.
Okay. And then this is more commentary. What is upsetting is we're in open enrollment now and the state has yet to post the new rates. We go through this every year.
They're posted. I'll show them to you.
Okay, great. And then is the Liberty Plus and Omni Tier 1 and Tier 2 based on your date of hire?
No, that was only in the 2019 plan, I believe, that they did that for state workers. That's more contractual.
Okay.
That was the CWA's baby.
Okay. And then another question is, how does the company offering the difference card make money?
There's a fee, a monthly fee per employee, like a PEPM.
Okay.
And they administer everything. The thing with you don't want to get into reimbursing from the side of the municipality because you get all the HIPAA restrictions. You don't want people bringing in medical receipts to you in your office. That way, the difference card, they've got to be HIPAA compliant and let them maintain the records. I'm not saying I'm not doing a commercial for the difference card either. I think they're great people, but there are other companies out there that do it. Your payroll companies do it. There's plenty of other places that you can do that.
Okay, so those are the questions we have now for now, Kevin, if you want to walk folks through.
All right, can you see my screen, the Google
We
screen?
can. Yep,
Okay.
we have the Google screen up.
So this is, I just want to make sure because the state has all the information on the website, but sometimes it's hard to glean the data you're looking for. So just type in SHBP, this is what's going to come up. Active members, if you're looking up retiree rates, just put SHBP retired. And it goes right here. Here's all your different options. It's very straightforward. So review your plan choices. Let's do that first. All right. So you look at local government employees for Horizon and Aetna, right? So let's just look at. So they have their propaganda up here. So, and Horizon has theirs. So then they go through a description. They produced all this. The state approved it. This is a side-by-side comparison. And because the state wants more people to go in the tiered networks, this is listed first on all the literature. I don't necessarily tell people what to, where to look on this page because you want to see where most people go. So you go to Freedom 10 right here. All right, and then it starts doing the comparison of in-network, out-of-network. And you can look at these different plans side by side. You can take this data and do a side-by-side comparison of deductibles, co-pays, co-insurance, and the like. If you look at when you get down to, this is what a lot of people are coupling the Freedom 2035 plan here. That's where they're coupling a lot of the HRAs with that. That's what Difference Card is doing. So if you look, the co-pays, there's a deductible to start, right? There's a $200 deductible to start, $500 max for the family. Out of network only pays 40% compared to 20. So if you look at all these differences, there's a lot of higher costs out of pocket. But this plan, remember, this plan is about $9,000 less than Direct 10 a year, and that's where it goes. And when you look at this all, it's all a shell game, because you take out or that's a bad analysis. It's a balancing game. If you pay less premiums, you're going to pay higher out of pocket costs, right? But what I try and tell people, look at the premium. Look at the out-of-pocket costs. If you take that money you're going to save out of your Chapter 78 contributions over a year and put it in the bank, then, you know, if you don't have outstanding, you know, real high medical costs, I guarantee you're going to, at the end of the year, you're going to have some money left. So, and then that's your money to spend. So that's just one. And then just in the interest of fairness, I'll look at Horizon's propaganda too. So, and they essentially break it up the same way. They tell you how great they are and how they want to save everybody money. And then you see the tier network is first. They put the same order on both of them. The state made them do that. So, and then you just can see what the out-of-pocket costs are for you and how it would affect your family. So you really need to look at this stuff before you make a plan choice, because you're actually, if you're over-insuring yourself, you're taking money out of your own pocket. So that's the plan choices, essentially. You always want to look at the local government side of things. That's what we fall under.
So Kevin, just 2 points. One, I put the links in the chat box, but they're saying it says for plan year 24.
Okay, I hit the wrong one.
Okay.
Yes, you see the way 24 is still on there, and then 25 is right below.
Okay, and in the chat box, disregard what I sent because they're both 24, not 25. I'll update that.
So yeah, no, that's what you can see here. It's for 25. All right, then you calculate your costs, right? So you want to look for plan year 25, local government, including RX. Now, some municipalities have a standalone prescription plan. Your town may do that or not do that. So that's why I say this gets really, it's really hard to talk to different towns, since I have members in pretty much every one. I have to look at their contract. I have to look, you know, at their at what their offerings are before I can make any determination or any help with them. So if you look at the rates here, these are the monthly rates, including RX. All right. So it starts with the 10 plans, right? Direct 10 plans. You can see that's $4,100 a month now for 2025. That if you go down to the Liberty Plus, which is their tier network, it's $2,800 a month. So this is how you figure all these numbers out. Look in this last column, and you can just determine, multiply that by 12, and that's what you're paying a year. So that's pretty straightforward. And always make sure you're checking the rate charts, because they all look the same. Just make sure the right dates are on there. Then prescription drug information is very important. So if you look at, where's the, all right. So you look at the guidebook is the rules. And then if you go to OptumRx, it'll take you to a tool that you can use, the formulary. All right. So active local government employees, then you can find out exactly. Here's the drug list. This is the formulary. This is what's on it. So you pick your plan.
Hi,
Right.
Kevin.
Yeah.
Hi, Sierra. I was having problems with my mic earlier. Someone wants to know if you're able to enlarge the slide. They may be having a hard time viewing it.
I don't know. Can I make this bigger? Can I zoom in? Yeah, I'm sorry. I don't know that.
Depending on your keyboard, Control Plus might do it.
Control plus. No.
Or you could click on, hold down
There we
your
go.
control
There you
button
go.
and then scroll up.
There we go. All right, so you can browse drugs alphabetically. So this, let's just say, what was one? Oh, like Dupixent is a big one that they're advertising. It costs. And the fun thing this is what I do for fun. I sit and look at the the Good RX app, and how much these drugs cost that they advertise. So if you want to have fun with that, but so I'm just going to try and get something that. Let me I just want to show you an example of one. All right, so whatever, I don't even know what this drug is. I just wanted to show you. All right, so it's tier 3 non-preferred. I'll tell you right there. So then you can figure out your copay. All right. So in the active side of things, there's only 2 copays, right? There's 3 and 10. With the retirees, there's 3 copays. So you click on there, and it tells you if you need prior authorization, step therapy, specialty med, extended days supply. So that's just a tool you can use when the doctor, when they tell you that something might not be covered. So, where were we? Direct primary care. This is an option open to all you too with any of the plans. We have a direct primary care model. If you read into this, we have facilities, and this pilot's been in effect for about 7 or 8 years. And you can go to this place. It's advanced primary care. They'll take care of you. We have one set up for law enforcement and fire. No copays when you access these places. There's some spots in New Jersey that kind of are lacking facilities, but the more populated centers, there's plenty of facilities around. And that's really. Here's just some other paperwork that you might need. But it's pretty comprehensive. I mean, everything you need is there. It's just learning how to navigate it. So, does anybody have any other questions or?
Yeah, we do. We have one
Okay.
the question from what I can see. Again, pardon me, I had some issues earlier. But the question I see is from Bonnie Sprouse. Can you explain the total out-of-pocket max amounts between Direct 10 and the other plans? There is a big difference in amounts.
Yeah, the Direct 10 has a much lower out-of-pocket max. All right, it's designed that way. So it really is what it is. So if you look at the out-of-pocket maximum for let's just use the out-of-network is $2,000 per person is the most you'll pay out-of-network. Then the plan pays 100% after that, or $5,000 per family. And then if you go to 2035, it goes up to $7,500, which is indexed yearly by the Affordable Care Act limits that are indexed federally. So yeah, that's the exposure that you're taking if you go out of network. So you have to be careful. That's why I said, ask the doctor how much it costs. You know, my wife got a neck surgery. They told me right then and there, I had to pay the whole out of network limit in one fell swoop because they moved it from December to January, and it was a new year. So I ended up writing a check for $2,100. And so that's why you have to have those conversations with your doctor. Don't be intimidated. You know, don't be intimidated. Especially hospitals. What does this cost? What does this cost? A friend of mine called 17 hospitals in New Jersey and asked how much it was to have a natural childbirth in that hospital. Do you know how many answered her? 0. She wanted to know the cash price, and not one person. And she did it as an exercise. But so you have to be upfront and say, listen, if you're not going to tell me what the prices are, I'm not going to come here. You really have to be a consumer. And if we could get people to be consumers, then we're in much better shape.
Okay, another question we have from Zanetta is Aetna Freedom 10, Aetna Choice POS 2, the same like Horizon New Jersey Direct 10 PPO plan?
Yes. Yeah, it is. Obviously there's some variations in the networks. I think most of them overlap. I think in the high 90s percent of doctors overlap. But yeah, it's the same plan design. It's because the state sets the plan design, and their POS2 network is their biggest network. It's their richest network for Aetna. That's what I'm in right now.
Okay, I had a question myself.
Go ahead.
Yes, I do. Were you suggesting earlier that if you have a Direct 10 plan, that would be more viable for a family of 4, 5, or 6? Is that something that you would say? 'Cause I heard you say if you have a baby and a family, then yeah, you would stick to those plans.
So if you have concerns about coverage issues and you're planning on it, it may be an option for you. Now, I will tell you, my son and daughter-in-law just had a baby. She's in the educator's health plan with Aetna, and it's a lower AV plan. It doesn't have as rich benefits as Direct 10. They had no cost out of pocket for the baby. So it doesn't. What you have to do is your research. You got to make sure your doctors are in it. All the hospitals are in both plans right now. So at the end of the day, if you want to take that, or if you develop, let's say somebody is diagnosed with cancer, they may want to switch to Direct 10 at the end of the year. That's one of the things nice for the employee on the state plan. But if you're relatively healthy and you're getting your physical every year, which is my other PSA, make sure everybody get your physicals, get your colonoscopies, get your preventative care. You're only going to make your life better, and that's money that we want to spend from the state perspective, right? That's from a plan, from the plan's perspective, I should say. But yeah, it could be a concern of yours. If you have an upcoming medical condition that you could switch into that plan for the year. But I ask you, is it going to be $5,000 out of pocket? If you stay in the Omnia plan or the Freedom plan. I don't know. It depends. You have to look at that and weigh that out. What's your cost savings going to be?
Okay,
Did I answer your question?
Yes, thank you. I just want to go over to Twallman, who wanted to know, did you say that Aetna POS 2 is on the same page as Horizon Direct 10?
Yes. Yeah, that's their best network. And like I said, especially if you're looking at the tiered networks, I strongly suggest you look at the Aetna plan, because their network is truly a national network. Like Omnia was never really an option for retirees because everything is tier 2, right? So you got a huge deductible at the beginning of the year. You're paying higher co-pays. If you do Aetna, it's not. There's tier 1 doctors all over the country.
Okay, and I think we don't have any other questions at the moment, but I will. Oh, wait, actually, there is one right here. Is Aetna POS 2 using also Optum RX?
Yes, the state only has one PBM vendor. So no matter what plan you go to, you're going to be with Optum.
Okay. So what exactly happened to Express Scripts? I know you said that's with
It's the state awards an RFP every so often. I think they're writing the new RFP for prescriptions right now. So when the state goes out, they award a bid. So and unfortunately, they write it in such a way that only the big 3 can apply for it. So what happened is Optum won the bid, ESI challenged it, and Optum still won it after they challenged it. But so Optum's got it right now. Their contract is expiring, so they go out to RFP again.
Gotcha. Kristen wants to know, is there somewhere we can access the 2024 plan costs for comparison?
Yeah, it's just on that website that I showed you. So, and that's, just go on Google, New Jersey SHBP, active members. And then you go review your plan choices and calculate your costs. That's what you want to look at. This will be the side-by-sides that I showed you. And essentially, whether it's Horizon or Aetna, the only real difference in networks is the only real difference in the plans is the Omnia plans, right? Otherwise, you have the same benefits in and out of network for both plans.
Were there earlier slides you showed earlier, I'm sorry, were there earlier slides you showed for pricing, did you say they were per month?
These
Yeah, the
this
slides,
per month.
yeah.
Yeah, that's per month. And that's right on the website. You just have to click on the website and calculate your costs, and then you can pick that. And you want, like I said, you want to make sure, because there's different rate sheets out there for different plans. And so you want to make sure you click the local active rate sheets.
Okay, and we had another question where one wants to know, what is the most accepted network in New Jersey, Aetna or BCBS? Blue Cross
They're
Blue Shield.
extremely competitive. They're about the same.
Yeah. Okay. In the beginning, I thought you were leaning more toward Aetna. I know you're saying that it might be a little more cheaper, given that the 2025 it might be changing.
Well, so here's when Aetna won the contract, right? And let me give you a little bit of New Jersey politics here. That bill that was written that said there had to be two different vendors in healthcare was generally written because people knew that Horizon wasn't going to win the bid. Okay, so that was a Horizon favorable bill and Horizon also knows that inertia is going to keep people in their plan. Aetna came in hot, had lower cost basis, and the state won't separate the rates. So we've heard up to 10% less on services. So what we'd like to see is, and that's why I went to Aetna, because I'm not going to preach it to people without doing it, but we'd like to see a big enough population move to Aetna, then they will separate the rates, they've told us. So we need like 20% of the members in there. But as far as services, I can tell you myself, I've had no issues. I certainly, I understand people wanting to stay with Blue Cross if that's what they feel comfortable with. But, we can't do anything right now to try and come up. If they separated the rates right now, what are people going to do? They're going to go to the lower rates, right? If I know I can save 10% of my healthcare, people would automatically go to that. Well, no surprise, some insurers have really strong lobbies and access to top level people. And when they talked about doing that, it got squashed. So, but that's the battle that I fight every day.
Okay, and you referred to the FHA plan earlier. Is that something statewide that comes with the benefit plans for everyone, or is that the FH? I'm sorry, the FSA. Right. So is that something that everyone can find in their benefits plan, or is that something that has to be offered by your specific organization or office?
Your municipality would have to contract with somebody for that.
Okay, got you. All right, and I do not see any other questions. If anybody has any other questions, though, you could drop them in the box before we close.
Okay, while we're waiting, last moment for questions, just want to again thank Kevin for your presentation. We'll be posting this online for on-demand review. And also a little plug, Kevin has written an article that will be in the November magazine dealing with hospital pricing. That if you found this presentation interesting, you will also find the article extremely interesting.
I'll put my email in the chat box too. If anybody's got any questions.
Wonderful.
Later on, it pops up.
Correct. So you can reach Kevin at KLYONS@NJSPBA.com. With that, we do have a last minute question. Will there be another one of these webinars before the October 25th deadline? At this point, no, we're not planning one, but you can view this on demand. And if you have further questions, you can reach out directly to Kevin or myself, and we can see if we can guide you. All right, with that, Kevin, thank you so much for your time.
My
and
pleasure.
Your knowledge and sharing it with us. And thank you for everyone for joining today's webinar. I hope-